All right. Hello, everyone. Welcome, and thank you so much for joining us today. In today's session, Entre Colegas, we are very fortunate and very glad to be joined by Dr. Marianela Rodriguez, who will be speaking about perinatal mental health. As everyone keeps joining, I encourage you to share your to share through the chat where you are connecting from, the state, your organization, and your role as a behavioral health provider. Um, Dr. Rodriguez, you can change the slide. Today's webinar is going to be simultaneous. We are going to be offering simultaneous translation to Spanish. So to hear today's presentation in Spanish, please go to the interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker's voice by clicking mute the original audio. Next slide. Now we will review a few housekeeping items. Today's event is being recorded and will be made available publicly through our website and our media channels. For today's webinar, all participants will be muted, although you can raise your hand so we can allow you to unmute. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having technical issues, please send a message to the Hispanic and Latino Behavioral Health COE on the chat box. If you have a question for our presenter, we ask that you use the question and answer tab on the toolbar. Simply type your question and hit send. We can address questions to the presenter at the appropriate time during today's presentation or at the conclusion of the event. We will be sharing a copy of today's presentation in PDF format through the chat box. We will also make a copy of today's presentation available to be downloaded through our website. You can find it under the name of today's event. Please, once we complete the session, we're going to be sharing an evaluation. This evaluation will help us know more about your opinion and thoughts about this presentation and other topics and trainings that you would like or feel that you would like to see offered. A link to the evaluation link will also be shared through the chat. You can also scan the QR code at the end of the presentation to complete it. And you will also receive a certificate of attendance by email approximately 1 week from today. Please remember to check your junk folder. Next slide. Our mission is to advance and support the sustainability of behavioral health by promoting community-driven, culturally grounded, and person-centered prevention, treatment, multiple pathways of recovery, and recovery support for Hispanic and Latino communities. And we strive to accomplish this mission through the development and dissemination of culturally informed, evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serve the Latino communities. As a few housekeeping items, next slide, sorry, Doctor. I would like to share that this is a safe space for everybody to share their ideas and experiences, and we encourage open and honest communications. This is more than just a webinar. We also like a dialogue when it comes to the topic. Please be respectful of others' approaches and experiences. We all come from different backgrounds and have unique perspective. Feel free to consult on clinical challenges and share your clinical achievements. This is a collaborative environment where we can all learn from each other. And please be cautious not to share confidential or identifying information about participants, clients, or patients. Now, next slide. Now, regarding our presenter today, Dr. Marianela Rodriguez is a clinical psychologist, certified perinatal mental health specialist, postpartum doula, and certified lactation educator. She completed her master's degree at Xavier's University in Ohio and went on to complete her PhD in clinical psychology at the Carlos Albizus University in San Juan, Puerto Rico. She has worked in diverse clinical and community settings for over 20 years. Over the last 10 years, she has exclusively exclusively work with the perinatal population in private practice, community programs, and also as an advocate for reproductive justice. She coordinated and led support groups for parents with perinatal loss, served as a postpartum support international coordinator in Puerto Rico, and currently is a consultant for the Puerto Rico Health Department Mother, Child, and Adolescent Division. Now, we know without any other delay, I'm gonna let Dr. Rodriguez begin her presentation. Thank you so much for joining us.
Thank you. And welcome, everyone. So excited to be here. I love the perinatal world. May is the Mental Health Awareness Month for for perinatal mental health. So this is very exciting to be sharing this topic with you today. I'm very excited too because I really enjoy hearing and learning about what others are doing, especially with the Latino communities. So, and in the perinatal period. So very happy to do Entre Colegas and hear what you have to say and how you're doing it. I'll be checking the chat and I'm really open to your comments throughout the presentation. So for today's objectives, I want to discuss a little bit about the social variables that are associated with perinatal mental health among Latinos, and then discuss some vignettes that display cultural values and hear what you have to say about this, and we can all discuss it further, as well as share resources that are available for support. And I'll begin with defining what perinatal mental health is. Perinatal mental health is a specific period of time, perinatal defined as that period of time from conception up to 1 year after birth. Very specific for mental health. And we know that this is a specific time period where we are most vulnerable to develop symptoms of perinatal or of mental health disorders. And when we talk about mental health disorders within this period, so we talk about mood and anxiety disorders. Mood disorders being depression, bipolar disorder, or psychosis, and anxiety being general anxiety, OCD, or PTSD. And I think it's very important to remind ourselves that when we speak about disorders, we're talking about conditions and symptoms that affect our mood, our thinking, our behaviors, and are interfering with functioning and day-to-day life. And I think that's one of the most important parts, because sometimes we think, and as we're going to be discussing here, specifically with Latino families, we think that these changes are expected, and we're expected to feel sad and expected to feel very anxious. And there's a fine line with the adjustment to motherhood and parenthood and a disorder and symptoms of a disorder. And when we talk about a disorder, we always need to really think about that interference of the functioning to day to day. Okay. So what do we know about perinatal mental health? We know that 1 in 5 mothers may develop symptoms for the first time during this period. We know that 1 in 10 fathers may develop symptoms as well. So very common, actually more common than other complications around pregnancy and postpartum, like gestational diabetes. We see more complications regarding perinatal mood and anxiety disorders than other physical symptoms. And that's important to be very aware and conscious about, because most of the care has been focused on physical changes and the physical care of the birthing person and the mother. But we really need to pay attention to those mood and anxiety symptoms and changes. 75% still remain untreated. And that's a very high number, because we know the short-term and long-term consequences of untreated mental health disorders, specifically with the mother, the baby, the family, and as a whole, as a society. when we have a mother or a pregnant person with an untreated mental health disorder, they'll most likely go less to their prenatal care. They won't take their vitamins as often or regularly as they should because disorders affect and interfere with your day-to-day functioning. They'll stop going to work or miss more work, therefore affecting their economy in their life, and affecting society as a whole. As a postpartum person with untreated mental health disorder, they're stimulate and engage with their baby less often. So it affects the entire family. And the consequences of untreated mental health disorders are huge. We need to be really aware. And right now, it's also one of the leading causes of maternal mortality within the postpartum period. So that is the worst consequences that could be. So very important to keep aware of this and the implications that perinatal mental health has within the birthing person, the baby's development, and the family. And I also want to highlight that we talk about perinatal mood and anxiety disorders and not just postpartum depression, which is what we hear in the popular, more common, what we hear more common. And we need to be aware that depression is just one of the many conditions that can develop and symptoms that can develop within this period. Okay. So let's talk about the prevalence with the Hispanic Latino community. I really want to make a focus here at the importance of doing more research with the Latino community. We know we're the largest ethnic minority group in the US right now, and that number is probably going to keep growing. And we have been typically underrepresented in the literature. So it's important to continue research and including our community. We know that 37% of Latino parents have suffered some sort of mental health disorder at some point. Up to 40% of Latina and Hispanic women giving birth will experience maternal mental health disorders, such as maternal depression. And perinatal mental health disorders occur more frequently in immigrant women than in women born in their host country. And that's, I think, a very specific and interesting fact to know and to keep in mind when we see our clients. And that research shows that Hispanic and Latina women are 41% less likely to initiate treatment for maternal mental health disorders than white women. And those are the nuances and uniqueness that we're going to be talking about. And as we talk about risk factors and barriers, we want to keep in mind that the Hispanic and Latino community is a very diverse community, and we don't want to stereotype all Latino women being the same. And we need to really be aware of where they're from, what are their specific cultures like, how much they align themselves with the culture's traditional beliefs and values, how acculturated they are to the US culture. And really, I always like to bring the example of myself because I was born in Puerto Rico. I identify as a Puerto Rican. However, I was raised in a Cuban household, and my parents were immigrants. And what we ate in our house, how we spoke, and different traditions were different than the majority culture of the Puerto Ricans. So if you ask me how I identify as a client, and I'll tell you Puerto Rican, and you don't ask a little bit more on how I was raised and how my values align with the Puerto Rican culture versus the Cuban culture, you're missing out on some of the important information. So we need to really back up a little bit and look at a wider perspective of the person that we're seeing, and not only how they identify, but how their family was raised, or how they were raised in in their household and what traditions they held and what's important. So really, person-centered approach is what I'm getting at, because we're going to be talking here about generalizations and some traditions that we may share as a community, but it's always important to keep reminding ourselves that we have a person in front of us, a very individual with a very unique history and perspective and what they've lived, experience, right? And so I think that's very important. So what are some common risk factors that we know that put our community and Latina women in a higher risk for developing symptoms of perinatal mental health? First, an unplanned and unwanted pregnancy. And we know we have a high prevalence of unplanned pregnancies. At least half of the pregnancies are unplanned. Single motherhood puts them at risk, and we know it's a higher prevalence in the Latina community. Poverty and lower education and everything that goes with poverty, and being marginalized in a community. Having lived stressful life events, which could be higher in families that immigrate to the United States. Lack of social support, especially if they're the only ones living in the United States and they don't have the extended family and friends that they had in their host country or their natal country. A history of prior mental illness, and that's personal prior mental illness and family history of family mental illness as well. So it's important to always ask about that as we are doing an intake and getting the history of this person. Non-citizenship is also puts a higher risk of developing symptoms. Cultural and societal stigma, and we're going to be talking about some of those a little bit more. About how the Hispanic and Latino community still holds a taboo around mental health and mental disorders. A higher prevalence of traumatic stress, so we need to always ask about that. We know that in our community, there's a higher prevalence of interpartner violence, up to 29.8%, and that puts us as a higher risk to develop these symptoms. And we're twice the likelihood of receiving late care, beginning in the third trimester of pregnancy or no care. And there's a lot of factors for that, and we're going to be looking at those coming up. And these are these barriers to accessing care. Recently, March of Dimes published some information about what they call maternity deserts, and that is how many people live within an area where they have no way of getting mental health services or OBGYN services, prenatal care. And we know that a lot of our community and Latino and Hispanic individuals may live more in the rural areas, that they need to travel further for care, and that could be a barrier to accessing care. If we talk about mental health specifically, the feelings of shame, stigma, and guilt might be there, and they may not see it necessary to attend to mental health services, especially during pregnancy or the postpartum period, which would be the happiest time in their lives. We need to add to that expense or lack of access to healthcare, as well as social biases in the healthcare system. We know that Hispanic and Latina women are less likely to be screened for perinatal mood and anxiety disorders than their white counterparts. And so therefore, there's less identification and less referrals, opportunities for referrals. Logistical challenges, such as lack of transportation or childcare. And this is really important. If we want to really support and provide care, we need to also look at transportation as well as childcare options. Some of the most successful support services that we have for the postpartum period, for example, is having childcare options for these mothers, especially if they have older children. They're not going to go to support groups or to therapy if they don't have a safe place where they can, that can take care of their older children, for example, and they cannot pay for babysitting either. I mean, it could get really expensive, so it's important. Another important factor of difficulties accessing care for this community is also their distrust of the healthcare system. As we know, we have a history of experimentation in our bodies, forced sterilization in the United States of Mexican women in the 1969 and in the early 70s, as well as for Puerto Rican women. We had also forced sterilizations and experimentations with birth control pill here. So there's a general and historical mistrust of the healthcare and medical system, especially when talking about prenatal care and access to the medical teams and birthing practices, etc. Fear that child protective services or relocation agencies will be involved, especially in this political climate. I think it's an important factor too to take into consideration of why we're not seeing as many Latina women going to their prenatal care visits or even coming or asking for postpartum visits or mental health services. The stigma, again, a fear of being considered a bad mom and what that means. And I think it's really important to explore that with the person that we're seeing. What does that mean? What does it mean to be a bad mother? And what does it mean to be a good mother? And just try to make sense of that and how each person interprets that different or perceives that different, and what are the behaviors that are around that. Okay. Sometimes a mother can feel like a bad mom because they have to go back to work. And what does that mean? And how does that make sense with everything else that's going on in their lives? Important to look at racial, cultural, and religious beliefs around motherhood and maternity and paternity and loss even that could happen within this period, as well as mental health symptoms and how do they interpret that. Okay. And language. We know language can be a specific barrier. When we talk about our feelings, most of us need to speak in our native tongue to really express what comes from the heart. Rather than from our mind, right? Just translating everything before we say it could be a barrier and could impact the therapy. So it's important, and having translation is not enough a lot of the times, right? So again, that importance of getting to a therapist, to a provider that looks like me, speaks like me, or can at least try to understand me. And that could be very difficult because we know there are not that many providers, especially in mental health, that speak Spanish in the United States and that know perinatal mental health. We're hoping to change that. So some norms that may impact perinatal mental health. And again, here, we don't want to generalize. We just want to talk about what we know and what the literature tells us about traditional Hispanic and Latino norms. But we also need to explore how this person that we have in front of us adheres to these or not. Familism is one, and having our family close to us for decision making and for big decisions, it's important for many of us. I think one of the important things here to acknowledge is, whenever possible, bring in the family, bring in the partners in therapy. to discuss this and to see their perspective and where they're at. And that family-centered perspective, like the family goes first and then the individual needs. Also, an important part of taking care of ourselves and receiving treatment and what that looks like. Personalism, I think it's another important one, especially when we're talking about therapy or services being provided. The person may be very agreeable. The Latino could be very agreeable in terms of respect and respecting the authority of the doctor or the therapist, but really may not agree inside, and they might not do what they said they would do in therapy. And that could be very frustrating for a therapist who doesn't understand this concept within the Latino and Hispanic community. So that needs to be brought up, and plans and treatment goals should be collaborative. And what do you think you want to do? And tell me what your plan could be with this. Okay. The cuarentena is a very specific tradition that I think in some parts have been kind of lost, but has been within the Hispanic Latino cultures for many, many years. And it talks about that postpartum period, 40 being 40 and being like the 40 days after birth, and how important it is that the mother be taken care of so that the mother can attend to the baby's needs. And so usually family support system, neighbors would come in, would take care of the mom, do the housekeeping and meals, prepare meals, usually hot meals. Were also important in some cultures, of like the chicken soup or some sort of guiso made that could take care of her body, and she could feed and breastfeed and take care of the baby or feed the baby. So I think that's kind of been lost a little bit just from not having the extended family, not having that support system to come in. But again, I think it's important to know where this person is with this and how important she thinks, her partner, if he's available or she's available with this time and taking care of her during this time, because it could be very incongruent for mothers if they've seen, or in previous births in their country they had that cuarentena and that help and that support with other children, but now as they're in the United States and they don't have as much family, this is not being upheld, and she doesn't have who to turn to for this time period and taking care of herself. And she feels like she needs to do all these things as she's recuperating from birth. So important to look at that. Then there's the two concepts of Marianismo and Machismo roles that kind of tend to those more traditional, rigid gender roles of male and female. The Marianismo also related to pregnancy and postpartum, how that there's a sense of duty and that mother identity and that sacrifice there's some expected sacrifice that we need to go through. Maybe even some sadness, just because it is so important to be a mother. And we need to understand that, because that may also present as a barrier to seeking mental health treatment if we feel like this is expected and we need to live through this as it should be. So that's an interesting concept too that we need to be aware about, especially in therapy, not to be confused with that the mother-centered also role of like the mother is the person that is the glue that keeps the family together, and all those roles that the mother has to take care of. So a little bit of the sacrifice, and then a little bit of also the just that leadership of the mother and the women within the family system, especially in traditional families where we go to our grandmothers for advice, and keep that in line. The machismo, again, that role of the father as a provider. A lot of times we see in the Latino families, the father not knowing how to take care of the baby, not feeling like they can do that, or that's their role, kind of asking permission to bathe the baby or change the baby, just because that's not what they've seen, that's not what they think they should be doing. And I think also, again, it's just being conscious of these roles and these traditions and seeing how they are impacting the client that you're seeing. I mean, maybe with younger clients who have been born here and just are more acculturated, these are not as rigid, but this is what they know too. So again, exploring that in therapy, I think it's very important. The experience of mothering outside of their home country, in a different country where they might not speak the language, they might not have a support system, they don't know where to go. And sometimes it creates a feeling of guilt if they have other children. Like I mentioned before, if they've had children where they were taken care of by their extended families in their country, and that birthing process was different, and that postpartum was different, and they feel guilty in a sense for their new baby that was born with no support around them, not the same baby showers or gifts or visits from family members, and exploring that also important. Also, there's a lot of multi-generational household living, people that many generations live in the same household. And while that could be very supportive for some families, it could also be very disruptive for others in terms of the boundaries. And there's a fine line with support and unsolicited support, and how sometimes if the person is younger, others take over and kind of limit their confidence and how they develop their confidence as a mother, because then there's a grandmother or an aunt or somebody else taking care and doing for them. And important to discuss that, as well as the religion and spirituality, and how does that play a role, if any, in their parenting and pregnancy and birthing practices or decisions. And the mental health stigma that we've talked about, and how it's still a taboo subject with many of our in many of our communities. So one thing I think it's really important too when we talk about work within the perinatal mental health field is to always keep, as a provider and a behavioral specialist, that perinatal lens as a framework. And what does that mean? That means looking beyond the signs and symptoms of a disorder and consider all of the areas that are impacting our client. When we have a perinatal client in front of us, we're looking at a person who is probably sleep deprived or is having difficulty with sleep, and we know how much sleep impacts our mood. So we need to think about strategies, sometimes practical strategies of taking care of that sleep hygiene. Who can help you? What can we do to improve your sleep? We're looking at a person whose identity has shifted in many ways, especially if it's the first-time mother, but how it changes from that sense of being a mother and what that means, and the things that they've lost in so many, in terms of identities and time, relationships. And when we have a person in the perinatal period, we know that the relationship will shift and it'll change, and those family dynamics get complicated. So we need to look at that also and think about that when we're talking about a person within the perinatal period. Financial strains, having a baby, it's costly, so we need to think about that too, and how that impacts the family, and how they deal with that. The same with, if, like I said at the beginning, if there's an untreated mental health disorder, and how I don't want to go to work. And if I do go to work, I'm not really there mentally. I'm there physically, but not as engaged. Maybe I have difficulty concentrating or really enjoying my job as I used to. There's going to be body changes. And I think that's an important area that needs to continue to be explored, and how women, the expectations of having their body back to what it was before the baby, and what impact that has on their mood, and how they accept their body changes, feel about their body. Also, if there's been a loss, perinatal loss, how they feel about their body not working for them, and not working the way they expected. If there have been fertility challenges as well, if they've had challenges breastfeeding. So all of that needs to be considered when we're talking about and when we're working with a perinatal client. Again, the cultural traditions regarding prenatal care, regarding birth, regarding postpartum. We need to talk about that and see and the implications that has on their mood, as well as their reproductive history. And we all have a reproductive history, but a lot comes out when we're in that perinatal period of what does that mean to me? How do I perceive it? How do I interpret it? How am I working through all the issues that could be related to losses or challenges that I've had throughout my reproductive years? Okay, so the importance of how we work around these and how we work with this clientele is certainly keeping it safe and creating a safe space where they can feel comfortable talking about what's uncomfortable for them. Okay. And it's very difficult to talk about not meeting the expectations of what it should feel like as a mother, when if everything you wanted was to become a mother, and now you're there and you don't know how you feel and where to say it. So it's important for us to always hold that space safely, that they can say what they need to say. And mothers feel very uncomfortable saying, I don't know if I love my baby, right? Because it's not what's expected. So from the society, from the messages that we get, it was not what she wanted, maybe, to experience. So being that person of holding that space, like you can say anything here, and you're safe to say it. It's important. So assuming a position of curiosity as well regarding their heritage and the Latino heritage, and how they are understanding and perceiving this time in their lives. It's important to know the communities as well, and who are the people that you're seeing in your office. We need to understand their educational level, their comfort with English, Spanish, or their need for speaking in an indigenous language, their dialects, their regional influences. And we want to educate ourselves about their countries and regions and where they come from. And that's on us. And that's how we create a safe space, right? We make space to talk about their relocation story whenever it's necessary. And we want to respect our clients' experience, that our clients' experience of parenthood in a way that is different from our own expectations, because we all have biases and thoughts about how parents should be and how mothers should feel and what it should look like, right? And always keeping ourselves checked in with those feelings and how we are, and when we're talking about our experiences versus our clients' experiences and what they need. I think also here it's important to talk about and discuss the possibility, and I open it to hear some of your thoughts about when we disclose our own history, our own situation, if we've had losses, if we've had difficult pregnancies, if our stories with motherhood and what that looks like. I would love to hear your thoughts. And this is an important part here in terms of the norm that I mentioned before about personalism and feeling close to your therapist, but also with respect, and how that looks with the Hispanic and Latino community. And I think it's something that we need to talk about as therapists openly. How and when is self-disclosure relevant? And if we use it, and if we do it, and what that looks like. So I'm looking at the chat. If you have any thoughts on that, I would love to open it up for that. Oops. I don't see anything, but so I'll continue. So these are some screening tools that once we create that safe space and that rapport, could be very helpful for a client and for us to understand what they're going through. One of the most, these are all in Spanish, available in Spanish as well. And one of the most used is the Edinburgh Postnatal Depression Scale, that we know is validated with many of our Hispanic and Latino cultures and communities. And that is self-administered, is easy, is free. And it's, it could be a very useful tool for our practice. I don't know how many of you are using it, if you've had any experience with the EPDS. We know it's called the Edinburgh Postnatal Depression Scale, but it actually it's been validated to be used in the prenatal period. So that's one of the most widely used. We have the PHQ-9, the postpartum depression screening scale, the generalized anxiety disorder, perinatal anxiety screening scale, the mood disorder questionnaire. We know it's a screening tool for bipolar disorders, and we know it's been very helpful to use with the Edinburgh when we suspect any other thing that it's not depression and it could be a bipolar disorder. We can use both screening tools, the PTSD checklist for trauma. We can use the Columbia Suicide Severity Rating Scale also if there's a positive on one of the Edinburgh or the PHQ-9s on their last one. The last question asks about suicidal intention or ideation in the last week, and we can use the Columbia Suicide Severity Rating Scale to validate that and verify and open it up for more conversation, as well as the Adverse Childhood Experiences questionnaire. And we know there's an Urban ACEs as well, which could be very helpful with this population. We need to understand when we do the screening, at what timing, when is it appropriate, and always remember that screening could just be a a paper if we don't open it up and do something about it, right? I think the screening tools could be very helpful, but we need to look at them. We need to look at those answers. We need to open up the conversation about it. It could be very powerful for clients to see how they're feeling in a paper. It kind of takes that stigma of this is just happening to me. This is actually a symptom. This is something that could be happening. So it could be very beneficial in therapy, but understanding when we do it. Thank you, Elizabeth. So you use the Edinburgh, the PHQ-9, and GAT-7. Awesome. And when, can I ask, when do you, what's the timing for screening? Because I think that's important too. Do we do it at the beginning? Do we want to, it depends also on our, or where we work, right? Sometimes it could be at the beginning, but sometimes we need to establish that rapport and trust, especially because we've heard about with this community some of the distrust of why are you giving me the screening tool? What are you going to do with those results? Why me? And how is this going to impact my relationship with my baby, my relationship with you? Are you going to call family services on me because of my punctuation or the results? So it's very important to give a little bit of course, getting the consent, but also understanding and having them understand why we're screening and how that could be very helpful for us to screen. Okay. Also, thinking about the ACEs, it might not be a good time to just give the ACEs right away because it talks about trauma and adverse childhood experiences that they may not have even thought about up to this point. And it could be helpful to give it after we've established trust with this person and rapport and letting them know one of the things we can do with the ACEs is to help you, understand what happened to you and understand that you don't have to repeat that and that doesn't define you, and understanding your adverse childhood experiences, and now that you're parenting a new baby, how you can do these things differently. Okay. Okay, and we also always want to ask about that cultural understanding. And I think I've covered some of these already, of understanding what motherhood looks like within your family's expectation, what skills you want to repeat and what skills you don't want to repeat in your parenting journey. What is the role of your mother or significant other in your journey? I think pregnancy and just matrescence, that whole transition of becoming a mother really, as an individual, puts us in a place of a lot of reflection. And who was our mother? How was I mothered? What does that look like? So it's an ideal time for psychotherapy, I think, for everyone. Of course, I'm biased because I'm a psychologist, but I really do think it's an ideal time to really explore everything that goes around becoming a mother and a father. Thank you, Elizabeth, for that. You explained the purpose and why we make referrals to clinics or support groups. Awesome. That this is to help you, right? And this is to understand what you're feeling. And I think I would even commonalize it a little bit and say 1 in 5 mothers could experience symptoms of a perinatal mood and anxiety disorder. 1 in 10 fathers, because the Edinburgh is also validated for fathers, may experience this. So so knowing how common some of these symptoms are, we want to know how you're feeling. We care about your emotional health as much as we care about your physical health, could be another approach, and having them understand what screening and the importance of screening and what that looks like. What role does the religion or spirituality play during this period of your life and parenting? I think that's a very important question, especially for Latino and Hispanic communities, and understanding where they come from with that perspective. How do you understand maternal mental health? What does that mean to you? Again, if they understand that maternal mental health is just part of being a mother and that you need to suffer, or that that's just common and that happens to everyone and it'll go away. We need to educate that symptoms of a perinatal mood and anxiety disorder are not going to go away on their own. We need treatment, like we need treatment for any other condition. Who do you go to for emotional support and understanding? We want to know, and thinking about the familism and the importance of family, we want to bring these people in and educate them as well, as they could be the first line of response for this person in case of an emergency. And they need to know what it sounds like and what it looks like to have a perinatal mood and anxiety disorder, so they know when to refer and when to take their loved ones to a clinic. And of course, do you want to tell me more about your experience of pregnancy and birth in another country? We want to open it up and hear more about that. Yes, thank you, Diane. To help mothers recognize that it's not their fault, no shame or blame. It helps to explain simple brain science as well. Yes, and how this is not your fault, or that you are broken, or that this wasn't meant to be for you. We need to understand what that looks like and what mental health disorders are and how they affect our brain and our bodies. And sometimes we need medications to stabilize these symptoms. Thank you for that. Would it be appropriate for us to use some of these questions when doing intakes? Yes, for sure. I think so. Glenda, thank you. And use images. Thank you for that too. I think that's very important, because we talk, and it might not, if we're not feeling great, we can't retain information. So we need to use other sources, like visual sources, and this is what it looks like. And this is what's happening in your body. Yes, that's great. And your brain. Thank you for that. So in summary, and before we open it up for some of the discussions of the vignettes that I've brought, we need to provide interpreter services. That's very important to have available. We want to recruit and retain key staff in our area, provide training to increase cultural awareness, knowledge, and skills that we can all be familiar with that. Use community health workers as well as traditional healers when needed. Sometimes we don't have to refer to a clinical psychologist. We need to ask what that looks like. What does that mean for them? How do they interpret that? Who else can be in the team? Yes, cultural resilience discussion, then assessment tools. That's great. Incorporate culture-specific attitudes and values into health promotion tools. Include family members in healthcare decision-making. Maybe we need to expand hours of operations in terms of being flexible, especially in the perinatal period, and how that looks and when I can go. I mean, maybe, depending on what our clients and our community. That's why it's so important to know your community and know what works in your area. And recognize our personal biases. Again, we all have them. Let's work through them. And I think that's one of the reasons these talks of Entre Colegas and between us, it's so good. Yes. Okay, thank you for that. Cultural awareness also super important. Sobadoras to then meet and process what their body releases. That's awesome. Not that many available, depending on the community again, but yeah, super important. Thank you for that. So I would love to hear some of what you think about this. Let's talk about, oops. Oh my God, sorry. So let's talk about M. She is 35 years old. She's married, Latina, graba one para one, meaning she's had one pregnancy, one birth. She's 3 weeks postpartum. She's a lawyer. She had an emergency C-section due to complications at birth. Baby was in NICU 15 days. They're both at home now. M's sister calls you at your office as she's concerned that M seems erratic, not sleeping well. And during her last visit, told her, I am not the right mother for this baby. She will be in heaven soon. When sister shared her concerns with M's husband, he indicated he's not concerned or worried as M is breastfeeding and taking good care of the baby. They spend the day together as he is back to work. He indicated this is all normal after birth. She will feel better soon, and my wife is not crazy. So I'd love to hear what are you considering at this point? What do you think it's important to acknowledge here? What would you do if you get this type of call? What are you thinking? What are your questions? Ask for clarification about her statement. Mhm. Anything else? This is the sister who's calling, so this is a statement that was done, and it just concerned her sister. What do we want to know? What do we want to know about M? What things are concerning? She's 3 weeks postpartum. Hadn't look at her history. That's interesting too, thinking about her degree and her high expectations. That's great. With baby being in NICU, shame, feel guilty. Yes, that's great. The NICU experience could be very traumatic for parents. Most of the times, this was probably due to the complications at birth, so this was probably not expected. This NICU stay of 15 days, the implications that has on the bonding with the baby, on how she feels, just that separation of and her body that is actually went through the C-section and complications and how she's feeling and recovering from all of this self-advocacy with medical establishment. Yes. What about the husband's statement? Do you have any concerns around that? Again, thinking about how much the family members know about perinatal mood and anxiety disorders and what they think this should look like, and how maybe some of this is expected. A medical social worker, super stigma. The stigma, and maybe thinking about, she looks fine to me because she's breastfeeding and she's taking good care of the baby. So she looks fine to me. And maybe understanding and knowing how to go a little bit deeper on that, minimizing concerns, or might not have an understanding of what postnatal depression looks like. Correct. Yes. And, this statement of I'm not the right mother for this baby, that's very concerning. And what that means that the babies will be in heaven soon could be a very concerning type. When we talk about postpartum psychosis, it usually starts right away after birth. And we need to be able to really rule that out. Because psychosis doesn't always look like, it waxes and wane. And we need to understand what's happening here a little bit more. She can be holding it all together in front of the husband. So she's, yes. So she's not concerned, right? As a sister, I would talk directly. yes, about her worries, and what she specifically said to the father so he can talk to her and find out about that significance around that. Yes, all these are great. I think that's very important. Um, you know, I recently there was an episode of Law and Order. I don't know if any of you saw it, but it had a little bit to do with a husband not wanting the wife to be in medications because he didn't believe in medications. And I take it it's a TV script, whatever. But I think it's worth the discussion of what happens if this gets worse. Who's responsible? And, what that looks like in this family dynamic. When we see a postpartum psychosis is a medical emergency, if we are concerned, we need to step up, and really get her screening and treatment right away. Right away. I'm concerned about the erratic behavior, the not sleeping. I mean, all these things will alter her mind, her behavior. Can family stay with her? Awesome. That is great too. Food be prepared and delivered by friends. How do we stay connected? How do we, follow her a little bit closer and see what's going on? Or if we really think as a sister that this is an emergency, we need to really take action and be very concerned about this and get her to screening and treatment. The sooner the better. Yes. Thanks for sharing all of those. Awesome. So here's another one that I want to open up for discussion. And it's a 25-year-old Latina female. Graba 3, para 0, so 3 pregnancies, no birth. She's 37 weeks pregnant right now. She has a history of congenital cardiac anomaly, being followed at a high-risk clinic. During her routine prenatal care visit, she was found with elevated blood pressure, dizziness, heartburn, and fluid retention. The physician, who actually was not her OBGYN, but the person that was there at that moment, recommends admission for induction of labor. The patient consulted with her family and left against medical advice. Tell me what you think is happening here, how you think things could have been done differently, if in any way. What are some of your concerns, and how do you think we can get her back and engaged in treatment? And what cultural considerations are you thinking about here, if any? Think about the importance of having family members in the discussion. What happened with this patient is she called her mom, and actually her mom said, listen, I've had high blood pressure with all my pregnancies and you were all fine. Natural remedies to control different health conditions, yes. That's usually the choice rather than an induction for many Hispanic Latinos, and the risk that comes with that. So this was not her OBGYN who makes the decision. So maybe there was this new physician or the physician who's in turno, who was in the at that point working, recommends induction of labor. How much did he go into, or she went into, her history and what she thought about the induction of labor if she wasn't ready for that? Again, the medical social worker, yes, for sure. How do we integrate? Did she even understand what she was being recommended to do? Did we give a full explanation of the concerns, like Irma is, mentioning regarding, let's talk about how she feels about this. What does it mean for her? I mean, she's had 2 previous losses. She's been pregnant 3 times. This is the one that has gone through 37 weeks. So there's that fear that it's right there. So we need to put everything in perspective. And what do we need to do to keep you here, and to keep you safe and to keep your baby safe? So all of these things important to, sometimes the medical professionals are just thinking the risks and this is what we need to do, and they need to, sometimes we need to open it up and hear what the family says, explain, take some time and explain. She might not understand what induction looks like, what that meant, that not all pregnancies are the same. Right. And that we're so close. And there's a high risk here for situation. There's dizziness, heartburn, fluid retention. So all these symptoms we need to think about, for a preeclampsia or whatever that could be happening, and ruling that out. So yes, so thank you for that. So here are some resources that are available in Spanish, English and Spanish. PSI Postpartum Support International has many virtual support groups that are free for the families that are online. And of course, if you didn't know, there is a National Assistance Mental Health line that is in English and in Spanish 24/7, which is a great resource that we should all know about and be able to refer and give out. Also, if you're working with a parent who is struggling, know that PSI has that helpline that is, there's a warm line also, and they'll return your call in 24 hours. PSI Postpartum Support International also has a directory of perinatal mental health specialists around the country, that you can go in and put the zip code and see who's around, if they have support groups, what are their hours and availability. And if you're a prescriber, PSI, or know of a prescriber, PSI has a perinatal psychiatric consultation line. It is not a 24/7 consultation line, but the physician can call and someone would answer them within the 24-hour period. Especially because there is so much disinformation and fear of keeping someone in their medication during pregnancy or postpartum or while breastfeeding. So it's important to know that there are many medications that are now available and that are not that are compatible with pregnancy and with breastfeeding, and we should not fear. We need to look at the risk, right? There's a risk of medication, but there's always a risk of having an untreated mental health illness during this period. So we need to have that conversation, and this is an awesome service of consultation for prescribers when they have questions. This is it for me. I'm going to open it up for questions if there are any at this point, and I appreciate you being with me this afternoon.
All right. Thank you so much, Dr. Rodriguez, for your time today. We're still going to allow a few minutes more for people to ask away if they have any more questions. If you could please change the slide so we can go to the post-event evaluation. I'm going to be sharing it also through the chat so everyone can start to do the evaluation. We would very much love for you to do it because it'll give you information and a space for you to share more topics that you would like to listen from ours. And also you can also request different products in Spanish and in English. So yeah, we're gonna be leaving this slide here for a few minutes, but also please feel free to ask away any questions that you might have regarding the topic or regarding any services that we do. Yes, the presentation is going to be shared with the participants. It is being shared through the chat. I am also going to be sharing it again. Nevertheless, we are going to be putting it up on our webpage today. So you'll be able to find it with the same name of today's event. Just as a quick reminder, we are going to be sharing or sending everybody a certificate of attendance by email approximately 1 week from today. And we will also be sending a reminder for this evaluation. If any of you didn't or don't feel it today, you will be receiving the link again per email. All right, so I guess if there are no more questions or anything, all is rest to say, thank you so much, Dr. Rodriguez, again, for your time and for such an excellent presentation. Certainly a very important topic. Yeah.
Thank you. Have a great afternoon.
You too, everyone. Have a great day.